Gastroesophageal reflux disease. Gerd is caused by frequent acid reflux, the backup of stomach acid or bile into the esophagus. When a person swallows, the lower esophageal sphincter, which is a circular band of muscle around the bottom part of the esophagus, relaxes to allow food and liquid to flow down into the stomach. Then it closes again. However, if this valve relaxes abnormally or weakens, the stomach acid can flow back up into the esophagus, causing frequent heartburn and disrupting their daily life. This constant backwash of acid can irritate the lining of the esophagus, causing it to be inflamed, creating esophagitis. Over time, the inflammation can erode the esophagus, causing complications such as bleeding or breathing problems. Gerd can also be caused by impaired gastric emptying from gastroparesis or partial gastric outlet obstruction. The amount of time acid is in contact with the esophageal mucosa relates to the degree of damage, and it may be caused by foods that affect the lower esophageal sphincter, such as caffeine, chocolate, or peppermint. It may be caused by motility disorders like scleroderma and esophageal spasms. The risk factors for Gerd would be an incompetent lower esophageal sphincter, obesity, pregnant women, cigarette and cigar smoking, and a hiatal hernia. An incompetent lower esophageal sphincter is the primary factor in Gerd. This results in a decrease in pressure to the distal portion of the esophagus, and the gastric contents move from the stomach to the esophagus. Most common symptoms is pyrosis, which is 30 to 60 minutes after meal and in a reclining position. The most common symptom is pyrosis, which is 30 to 60 minutes after meals and in a reclining position. May have spontaneous regurgitation of sour and bitter gastric contents into the mouth. Patient could have epigastric pain, dyspepsia, nausea, and vomiting. Now, dyspepsia is also known as indigestion or an upset stomach. It's a term that describes discomfort or pain in the upper abdomen. Dyspepsia is not a disease. The regurgitation is described as hot and bitter. They'll have chest pain, especially at night while lying down. Difficulty swallowing, known as dysphagia. And there are several factors that might explain why reflux occurs and offer some clues. The positioning of the body after eating. An upright posture helps prevent reflux. This is where gravity is your friend. The size of the meals. The smaller meals reduce reflux. The nature of the foods that are eaten. There are certain substances that irritate the esophagus and weaken the lower esophageal sphincter, like fatty foods and spicy foods, caffeine, chocolate, peppermint, and even drugs like anticholinergics. In addition to irritation and inflammation of the esophagus, esophagitis, chronic reflux of stomach acid into the esophagus can lead to esophageal narrowing or stricture. Strictures occur in some people with Gerd. Damage to the cells in the lower esophagus from acid exposure leads to formation of scar tissue. The scar tissue narrows the food pathway, causing large chunks of food to get caught up in the narrowing and can interfere with swallowing. Esophageal ulcer. Stomach acid can erode tissues in the esophagus, causing an open sore to form. An esophageal ulcer may bleed, cause pain, and make swallowing difficult. Barrett's esophagus. This is a condition in which the color and composition of the cells lining your lower esophagus change because of repeated exposure to stomach acid. This exposure to stomach acid is most often a result of long-term gastroesophageal reflux disease. Endoscopy is done to visualize lesions or erosion. A biopsy would confirm a diagnosis. Esophageal manometry measures lower esophageal sphincter pressure and determines if esophageal peristalsis is adequate. Bernstein test is also known as an acid perfusion test. If the patient has an onset of symptoms after ingesting dilute hydrochloric acid in saline, it is considered positive. Bravo pH capsule system is radiotelemetry. A pH sensor is inserted into the esophagus, and this is 24-hour monitoring. It is contraindicated for patients with pacemakers, implantable defibrillators, or neurostimulators. It is contraindicated for patients with history of severe esophagitis, varices, obstructions, bleeding diatheses, or strictures. Barium swallow. The X-ray is used to spot abnormalities such as a hiatal hernia or other structural or anatomical problems of the esophagus. The test will not detect mild irritation, although strictures, narrowing of the esophagus, and ulcers can be observed. An upper endoscopy is to see the surface of the esophagus and search for abnormalities. Ambulatory pH test. The physician will insert a small tube into the esophagus or clip a tiny device to the esophagus that will stay there for 24 to 48 hours. The patient goes about their normal activities, and the device measures when and how much acid comes up into the esophagus. This test can be useful if combined with a carefully completed diary, recording when, what, and amounts the person eats, which allows to see correlation between symptoms and reflux episodes. This procedure is sometimes helpful in detecting whether respiratory symptoms include wheezing and coughing are triggered by reflux. Esophageal impedance, a test to measure the movement of the esophagus. It measures movement and pressure. The test involves placing a catheter through the nose into the esophagus. Antacids. Despite the development of potent medications for the treatment of GERD, antacids remain a mainstay of treatment. Antacids neutralize the acid in the stomach so that there is no acid to reflux. The problem with antacids is that their action is brief. They empty from the stomach quickly in less than an hour, and then the acid reaccumulates. Since the food for meals slows the emptying from the stomach, an antacid taken after a meal stays in the stomach longer and is effective longer. For the same reason, a second dose of antacids, approximately 2 hours after a meal, takes advantage of the continuing post-meal slower emptying of the stomach and replenishes the acid neutralizing capacity within the stomach. For mild to moderate symptoms, Maalox, Mylanta, and Gaviscon. H2 receptor antagonists control or eliminate acid, but might not be as effective as proton pump inhibitors. Some of these medications are available over the counter, but should not be used for more than a few weeks at a time. Because these medications work differently, a combination of drugs may be given to control the symptoms. Proton pump inhibitors. The proton pump is a molecule in certain cells of the stomach. It pumps acid into the stomach. It takes a non-acidic potassium ion out of the stomach and replaces it with an acidic hydrogen ion. This hydrogen ion is what makes things acidic. By putting more hydrogen ions into the stomach, the pump makes the contents of the stomach more acidic. But by stopping the action of the pump, acid secretion in the stomach is stopped. Proton pump inhibitors should be taken 30 to 60 minutes before meals for optimal control of gastric acidity. Proton pump inhibitors are more effective than H2 receptors in achieving faster healing rates for esophagitis. But remember, patients with renal insufficiency and elderly patients may need to decrease dosing of an H2 receptor antagonist. And Reglan can be given, but it can affect the central nervous system from anxiety to tremors to hallucinations. A step-up approach is when the patient first tries an H2 blocker drug, which is available over the counter. If the condition fails to improve, therapy is stepped up to a more powerful proton pump inhibitor, usually omeprazole. A step-down approach first uses a more potent agent, most often a proton pump inhibitor like omeprazole. When the patient has been symptom-free for 2 months or longer, they can then step down to half a dose. If the symptoms do not reoccur, the drug is withdrawn. If symptoms recur, the patient is put on high-dose H2 blockers. Surgical treatment: treat the symptoms, heal the esophageal damage, prevent complications and relapse. Elevating the bed 6 to 8 inches for the patient not to lie down 2 to 3 hours after eating. The most common procedure is a Nissen fundoplication, in which the upper portion of the stomach is wrapped around the distal esophagus and sutured to create a tight lower esophageal sphincter. This can be done laparoscopically. People can usually leave the hospital in about 1 to 3 days and then return to work in 2 to 3 weeks. Other endoscopic techniques to treat chronic heartburn include the Gerd endocinch system. This technique requires the use of an endoscope to perform an anti-reflux procedure. The endocinch systems involves putting stitches in the lower esophageal sphincter to create pleats that help strengthen the muscle. The Stretta system uses electrodes to create tiny burns on the lower esophageal sphincter. When the burns heal, the scar tissue helps toughen the muscle. Nursing management. Discuss the medications that could exacerbate GERD symptoms. The patient should sit or stand when taking medications and drink at least 100 ml of fluid. Raise the head of the bed at least 6 inches to allow gravity to keep the stomach contents in the stomach. They can put blocks under the posts of the bed or use 1 to 2 pillows to elevate the head when lying down. Tell the patient to not use piles of pillows, because all it does is put the body in a bent position that can actually aggravate by increasing pressure on the abdomen. Eat meals at least 3 to 4 hours before lying down and avoid bedtime snacks. The best thing is to eat smaller meals. Maintain a healthy weight to eliminate unnecessary intra-abdominal pressure caused by extra pounds. Limit consumption of fatty foods, chocolate, peppermint, coffee, tea, colas, and alcohol, all of which lower the esophageal sphincter or delay stomach emptying. Also avoid tomatoes and citrus fruits or juices, which contribute additional acid that can irritate the esophagus. Give up smoking, which relaxes the lower esophageal sphincter. Wear loose belts and clothing, and usually a bland diet is preferred. Since a patient could be at high risk for aspiration, it would be important to assess their breath sounds. Complications would be an esophageal stricture formation, ulceration of the esophagus with or without fistula formation, aspiration that can lead to pneumonia, and development of Barrett's esophagus, which is a precursor to esophageal cancer. When getting ready to discharge to home, the patient should not undergo an MRI within 30 days of having a Bravo capsule pH monitoring. Do not overeat, as this causes lower esophageal sphincter relaxation. Eat small meals and do not have a bedtime snack. Patients should eat foods that do not decrease the lower esophageal sphincter pressure. Peanut butter would also lower the pressure. Fruit and gelatin are low fat and will not decrease the lower esophageal sphincter pressure. No tight clothes. Stop smoking. Decrease alcohol. Avoid straining and bending over. Sleep with the head of the bed elevated and not just with the pillow. And weight reduction can help decrease the intra-abdominal pressure.